Hello, I'm Dr. Maria Sulindro, and everyone knows I'm practicing integrative anti-aging medicine in Pasadena, California. But I have a guest speaker today, very dear friend of mine, Dr. Howard Elkins. I'd like to introduce you his background. Dr. Howard Elkins is a cardiologist. He is practicing integrative cardiologist. Now, Dr. Elkins graduated with the highest honors from the Medical College of Virginia in 1979. He's 1 year ahead of me, only 1 year. And then he completed his internal medicine residency at Michael Reese Medical Center in Chicago. He had done clinical fellowship in cardiology at Northwestern University in Southern California in 1984. And we are so blessed to have him back here since 1984, practicing cardiology in Whittier, California since 1986. So, hi, Dr. Elkins.
Hi, I'm so glad to be back. Thank you for inviting me, Dr. Maria.
Uh, yes, we need integrative cardiologists very badly in this area, especially. So I'm so blessed to have you willing to do this YouTube together. Okay. Now, today's topic. Interesting, very interesting because we are wondering, are heart palpitation dangerous? And Dr. Elkins will actually share with us, and hopefully you have some questions, but I personally have some questions. So Dr. Elkins, this palpitation means different things to different people. How do you describe this phenomenon?
A great question. And I always hear the thing, it does mean different things for different people, but to me, it's just an awareness of your heart, whether it's pounding, skipping beats, fluttering. It really is very subjective, but I'm going to give you Webster's definition because I looked it up. Palpitations by Webster is a noticeably rapid, strong, or irregular heartbeat due to agitation, exertion, or illness. That's pretty fancy, but I just think it's an awareness. Some people feel it in their heart, some people feel it in their neck, some people feel it in their jaw. So it really does mean different things for different people. So, but it's just a subjective sensation that something isn't right with your heart rhythm.
Wow, so some people feel it in their jaw.
Yes, yes.
Wow. Okay. Let's see what we have at the end here. And what are the common symptoms?
Okay, the common symptoms are skipping beats, the heart's beating too rapidly, the heart is skipping beats, there's flip flopping, or sometimes people describe a fluttering like a butterfly in the center of their chest. So again, there's so many different things.
Mm. So okay, how about we put it this way? What are some of the most common causes of palpitation?
Right. The most common causes are, okay, first of all, anxiety probably is top of the list. And I should also just preface by saying that most palpitations are really of a benign nature, but there are certain times, certain situations in which you have to be concerned about it, and we'll discuss that. So a strong emotional response, fight or flight, panic attacks. I've seen many people come to my office thinking that there's something definitely wrong with their heart, and we work them up, and thank goodness everything is okay, but it's often a panic attack which brings them in there. And you have to know that about of all visits in the primary care physician's office and the emergency room, about 16% of these visits are based on palpitations. It's palpitations that bring in the office. For cardiology practice, it's much more than that. It's a very common symptom. Sometimes depression, strenuous exercise can bring it on, which can be an ominous thing. Stimulants, caffeine, amphetamines, cocaine, of course, but also some common cold medications like anything with pseudoephedrine. Now I think they keep that behind the counter, but in the old days you could just pick it up. Pseudoephedrine is definitely a stimulant. It can stimulate the heart. Fever, okay, hormonal changes that we see in pregnancy and also in menopause. Too much or too little thyroid, and also low blood pressure, low blood sugar. Okay, low blood sugar can do it, and also low blood pressure. So these are like secondary causes. So the heart is kind of like responding to external forces, and it's kind of like it responds by rapid heartbeats or skip beats or whatever you want to call it. So those are the common causes.
I see. So now, if those are the common causes, when do these become serious to the person or to the patient? So
I think the heart beats about 100,000 times a day. And so if they're greater than like 100 extra beats in that period of time, it could be of concern. Now, I don't go by the numbers. So if a patient comes to my office and they're complaining of palpitations, and I also have to tell you, I have to tell them, what do you mean by palpitations? What does it mean to you? Because I'm sure I've had some in my life, but I've never felt a palpitation. I don't know what it feels like. So I have to, really carefully ask the patient, what do you mean by that? What are the symptoms you experience? And then, I will oftentimes order a 30-day monitor. We used to order a thing called
a 3 days monitor.
Right. Now, Medicare and most PPOs will pay 30 days.
30 days. Oh, 30 days. I didn't hear it wrong. Okay.
Yes, I picked, yes. So, in the old days, remember they had that big thing you had to wear around your waist? Now it's like a little adhesive and you just clamp the monitor on and it's wireless. It's totally wireless. And you have like a little iPhone that transmits the data, but the quality is superb. It's as good as an EKG. So that's going to give me a lot of information. It's going to let me know the fast heartbeats, the slow heartbeats, how many extra beats there are, and if there's any arrhythmias. So I didn't mean to jump the gun, but that's a very important diagnostic tool that's covered by Medicare and essentially every insurance.
So when you said that you were sure you had it, but you did not feel anything, what do you call that?
Well, I'm sure I probably have had premature ventricular beats or premature atrial beats. These are terms that we use. If it originates in the upper chamber, it's called a premature atrial beat. If it's in the lower chamber, it's called a premature ventricular beat. And they do mean different things. So, but I've never felt an extra beat in my entire life. Can you imagine that? Now, some people, I've also examined a lot of athletes from Biola University and Whittier College. So I've had a lot of experience with young people, and some of these people, it's picked up by their coach. And now with the liability and so forth, I get a lot of consults with young people. Some of them have like so many extra beats you can't imagine, and yet they're totally normal. They feel nothing. So it kind of scares the coaches.
Okay, so what you mean, some people can have documented palpitation, but they do not feel anything.
Correct.
And some people can have nothing documented and they feel it.
Right.
See, okay, everyone, you hear that, okay? So this is very important then. So are there particular risk factors to it?
Yeah, the risk factors are definitely highly stressed individuals that kind of work with, they're always in fight or flight kind of mode. Also, people with anxiety disorders, that's going to make a difference. We see it a lot in pregnancy. And certain medications, like I said, even asthma medications. Asthma medications are very common because they're bronchodilators and they're important to open up the passageway to the lungs. However, they're also agonists into the heart, and they actually can cause rapid heartbeat. So I always ask, what medications are you on if you're taking any medications at all? And also a big one is thyroid, especially overactive thyroid. It's very important to check that. And of course, the bottom line, heart problems. Now, I want you to know that the majority of people that have these palpitations, it's not anything related to the heart. We work them up and thank goodness everything's normal. But people with heart disease, we have to be very careful. I mean, you can see it with hypertension, you can see it with coronary artery disease, you can see it with people that have primary arrhythmias, and we'll talk about that in a minute. So heart disease is a whole different matter.
Okay, thank you so much. What kind of complications could there be then?
Good. So complications are, if it is a heart problem, Okay, if it's a heart problem, it could lead to prolonged arrhythmias. Now, a lot of arrhythmias are benign. Like there's one called like supraventricular tachycardia, which is a big word. It just means that's a rapid heart rhythm that's abnormal, but it generally isn't life-threatening. Then we have atrial fibrillation, which I'm sure a lot of you have heard. That's a most common arrhythmia in those over the age of 70. And I think it's seen in a huge population of people, and it's growing because the population is getting older, of course. And now these people can, it's very important because these people can develop a stroke. So when I probably get about three, on the average, three people coming to my office monthly with new onset atrial fibrillation. Just you heard about it because it's real. And that those people can present with a stroke. So it's very important to make sure you don't have atrial fibrillation.
So let's describe it a little bit about this atrial fibrillation. How are they going to know that they have this atrial fibrillation then?
All right. So what they will often notice, what they should notice is an irregular heart rhythm, or some people I've had people just have shortness of breath, just out of the blue, shortness of breath. They don't even feel the irregular heartbeats. Chest pain can do it. So I tell people, if you feel any symptom that isn't your typical, get checked out. If you can't go to your doctor's office during that day, you can go to the emergency room. I really feel we don't want people to be left out in the dark. We don't want to miss anything, because there are some people that can present with stroke. Some people don't even know they're having it. They just feel faint-like. So faint is another. So faint, chest pain, shortness of breath, rapid heartbeat. All these things are symptoms that you could develop that can lead to, that atrial fibrillation. Now, go ahead. Mm-hmm.
You had mentioned about anxiety several times. Can anxiety people presented with non-objective finding, and what do you call that?
Good question. I mean, I do a lot of monitoring, as you can imagine, and some people are feeling flip-flops and beats that aren't there. I can't tell them that they're that fabricating, but I mean, they're wearing a monitor, and they keep a record, by the way, so they can, with the little iPhone they give them, they can easily like punch in, okay, chest pain, palpitations, rapid heartbeat, faint-like feelings. They have a choice they have choices, and then I correlate that when I see them for follow-up. And sometimes I see something, sometimes I don't. So it just means I don't discount their feeling. It's just they're feeling something that we don't pick up, that we don't objectively see. Doesn't mean they're not feeling it. I always give the patient the benefit of the doubt, always.
Okay. I'd like to ask you, because you are integrative cardiologist, what natural therapies are there to offer?
Okay, a lot of really good things. First of all, relaxation, meditation. I meditate every day, and I recommend that everybody pick up some type of meditation practice. So meditation is good, really working on your breathing. When I meditate, all I think about is one thing, my breath. And if my mind deviates, I get back to my breath. I always come back to my breath. So that's really important, deep breathing. And I teach my patients how to do that. That's part of my what I teach them. That's my prescription. It's not always a medication. It's oftentimes how to breathe. Yoga, Tai Chi, these are good also practices, because these things keep you in the moment. Okay. So other things that slow your heart rate down are activities that you love. Like I like to sing. I love to sing. So singing to me is a Zen-like activity. So it's keeping it's keeping myself in the present moment. And so many of us, especially with COVID, it's been a very difficult 15 or 16 months. We're always, we're anxious at the present time. We're worrying about the future, and we really can't do that. We have to take it day by day. That's what I've learned in my life. So those are some natural things that you can do. Something I do, and I wouldn't do this without checking with your doctor. I take cold showers every morning. And that really also stimulates the vagus nerve. And the vagus nerve stimulation is an important adjunct that you can do to help slow things down. So deep breathing is one thing. Cold immersion is another. Again, I wouldn't do that without checking with your doctor, but I do it.
Exercise.
Exercise is Very important, because when you exercise on a regular basis, you're teaching your heart to slow down, believe it or not. So, so that if ultimately you can do more with less effort. Like I have some people that have no heart problem whatsoever. They come to my office, we're doing a stress test, and they walk from the bench to from the table to my treadmill, which is maybe 15 feet, and they're already, their heart rate's gone from like 80 to 110, doing
Wow.
nothing. So I have other people that, so the better condition you are, the lower your heart rate. You probably heard that before. So,
I
oh,
see. Okay. Well, good. So, Dr. Howard, I mean, Dr. Dr. Elkins, when do supplements help these patients?
I'm sorry, say that again. I didn't hear it.
When do like food supplements help these patients? Do you
Okay.
think there is a place for that?
Yes. Okay. First of all, the most important thing, well, as far as supplements are concerned, I really like magnesium. So magnesium is used in about 350 some chemical reactions in the body, enzyme reactions. And most people are deficient in it. About 55, 60% of Americans are deficient in magnesium, especially in the summertime when it's hot because you sweat. But it also helps with sleep, and it helps to regulate your heart rhythm. That's one of my favorites. Also, there's something called taurine, which is a natural occurring amino acid, and that also can be very helpful in calming the heart. Food, okay, so you want to avoid certain foods. I think one that you need to avoid is tyramine, which is an amino acid, and that is seen in certain. What am I thinking of? I can't think of right now. But there's certain.
Corinne, you
That's
were.
it. But taurine is very good.
Okay. So taurine is natural,
Amino
can
acid.
natural is amino acid, but can be work. It can work as a diuretic for me. Yeah.
Also good for the brain.
Yeah.
It's got a lot of good uses.
Yes. And for my patients and listener, I would suggest because I am a victim of low magnesium syndrome, and I do have a gene problem in that. So I know a lot about magnesium, and in fact, my when I the initial story was when I became a patient of with the diagnosis of hypomagnesia. I actually learned how to take magnesium, and since then I learned about which magnesium is best for which patient. And apparently a magnesium for everyone is personalized. It's very
Yes.
those dependent on the personal. So when you take magnesium, you have to be very careful and make sure that you notice the change of your stool, and that is your dose. And then don't get to into diarrhea, but when you have diarrhea, actually is hallelujah, it's better than constipation. And
Right.
then when you get that to diarrhea, you cut a little bit back to like 100 or 200 milligrams. Now, personally, I take about like almost 3,000 milligrams of magnesium bisglycinate. If not, I'm not good. And then some of my patient takes more, but some of my patient cannot even tolerate. That's about magnesium. I really have to do title of magnesium because that's my field. Now, Dr. Elkins, uh, when when do you see that medication actually necessary then for palpitation?
Really an important question because uh, for the average arrhythmia, I don't really like medications. I'll tell you why, because they're really not that effective and they don't really work that well, and they have side effects. But let's talk about common arrhythmias like SVT, which is, you know, if now SVT stands for supraventricular tachycardia, and that's a very regular um, arrhythmia. It's brought on by exertion, stress. I have see a lot of athletes with it. If they have this feature, I saw a person at actually Baylor University several years ago. She was here from, I think, Croatia. She was on a volleyball scholarship, very tall, and she during practice she would have these runs of arrhythmia. So back then we had 24-hour halters, and fortunately I got it. And then we sent her to an electrophysiologist to have an ablation. So why? Because it's actually better to have an ablation than medication for that. But what I want to emphasize is atrial fibrillation because it's so common and it's on the rise. Now, atrial fibrillation, and it's really important. We call it, the heart is beating irregularly irregular. There's no rhyme or reason to it. It's all over the place. And the first goal is to slow the heart rate down. Heart rate control is very important. And then my second goal is to try to convert the rhythm to normal rhythm if I can. I'm not always successful. And that's when medications come in, because medication, if you're in atrial fibrillation, the most feared thing is a stroke. And there's like a 30 or 40% incidence of stroke. And when does that happen? If you have atrial fibrillation that's lasting for longer than 8 hours. And that's again when the monitor really comes in handy, because I'll see people with short runs, maybe last half a minute. I'm not terribly concerned. But once I start seeing 6, 7, 8, or 9 hours, that's telling me that that there's a propensity for clot to form and one of the heart chambers, and that can break off and go up the neck to the carotid artery and cause a stroke. So it's really important that these patients be on a blood thinner if they have atrial fibrillation that's persistent. It could be chronic or it could be paroxysmal, meaning it comes and it goes. But if it's lasting greater than 8 hours, we need to have a blood thinner. There's no substitute for, people say, is there anything natural I can use? And that's a good question. It used to be, up until a few years ago, that if you were under the age of 70 and you had atrial fibrillation, you could just use aspirin. But they have since found that it doesn't really compare to a real anticoagulant. And now we have a few choices. No one wants to be on a blood thinner, but no one wants to get a stroke either. And the stroke that you can get from atrial fibrillation is not a small stroke. It can be a very large stroke. Because imagine, it's going from the heart up to the neck, and it can cut off a major blood supply, which could lead to a very large stroke. So that's the other thing. And what about medications? There are some medications that we can use for atrial fibrillation. Do they work? Maybe 40, 50% of the time. Lots of times they're ineffective. And that's when we sometimes go to an ablation, which is an invasive procedure done by a cardiologist, not like me, but an electrophysiologist. And they actually can go up to the groin and they can find out where the atrial fibrillation comes from, and they can zap it with either cryotherapy or with radio frequency waves. So the most important thing, I want to get all my patients in normal rhythm. I don't want them to be in atrial fibrillation. So I will do whatever I can to get that way. But the most important thing, and here's what you need to know, there's 4 things that happen with fibrillation. It's not life-threatening. You don't drop dead of it. It's not a life-threatening arrhythmia. But number 1, stroke is the most prominent thing to worry about. Number 2, heart failure. Because if the heart's always beating fast, it's gonna poop out after a while. I had a patient up about a year ago, one of my cardiac patients, and he did not want to get a conversion or ablation, so he didn't want any medication at all. Heart rate was like 110 just sitting in my office, and he was short of breath doing anything. I said, you got to slow down. If you want to stay in AFib, that's your business, but we need to slow the heart rate down. And he finally did, and he's doing much better. So heart failure, stroke. Another new thing to be concerned with is there's now saying to see that people that have, even if it's paroxysmal, meaning it comes and goes, people with atrial fibrillation have a increased incidence of dementia. New finding, which I think is very interesting and very important, because nobody wants that. So I really try to get people out of atrial fibrillation if I can. I can't always, but it can be a challenge. It can be a challenge, but it's so common. Like I said, I get about 3 people a month.
Based on that 3 a month is pretty high numbers.
Practitioner, yeah.
Yeah. Based on your experience, when you put them on medication and get the arterial fibrillation controlled and they're in sinus rhythm, do you have an idea like what percentage of them can be off the medication and be put on your super supplements for the heart?
Great question. A few years ago, we didn't have that information. So like I had a few patients, let's say I was able to convert them. Sometimes we do what's called a convert cardioversion in the hospital, which we put, paddles on the patient's chest, they're put to sleep. It's a 5-minute procedure. And we shock them. out of fibrillation to a normal rhythm. And I've been very successful in that. And in the old days, I'd seen them for follow-up, maybe 2 or 6 weeks down the line, and I would take them off blood thinners if things looked good. Now, we didn't have any information. Now we have something called the CHAD score. And the CHAD score is like a point system. So I think it's 3 if you're a female and 2 if you're a male. And what that means, if it's 1 point is if you're over 65, if you have history of hypertension, if you have a history of diabetes, if you have a history of congestive heart failure. So each one of these entities adds another point. So if you're 2 or above for a male, you should be on anticoagulation, whether or not you're in atrial fibrillation, because there's about a 40% incidence that it may come back. We never know who's going to come back and who's not. And if it's a female, I believe it's 3. So that's a point system that we now have, which we didn't have like 15 years ago. So, I have a few patients that develop atrial fibrillation years later. And thank goodness I didn't have anyone have a terrible outcome, but I had one that did develop a stroke. You're talking 15 years after they were cardioverted. So it can happen. So we have to be very careful, but the CHAD score is something that we can all use now to help kind of outline how we should handle these patients on a long-term basis.
So your patient, the one that had the 15 years history of sinus rhythm of fibrillation, then she had a stroke. Did you actually monitor her every year, and she out of
I did stress testing and I follow the patient carefully, but back then we didn't have the monitors that were good for 30 days. I mean, now having a monitor for 30 days is a incredible tool, because I can tell who needs a pacemaker, who needs this, who needs nothing. Yeah. And before I didn't have that information, it was kind of like an educated guess.
Mm-hmm. Mm-hmm. So what is the difference between palpitation and arrhythmia?
Good question. All right, so palpitations, again, it's subjective. The patient feels something that's just not right. Arrhythmia is something that we pick up as doctors and nurses. We do an EKG, we see the rhythm, we see a rhythm strip, so we see extra beats or just an abnormal heart rhythm. So it's really an abnormal heart rhythm. Now there's different types of arrhythmias, but again, so palpitations is what subjective the patient feels. And arrhythmia is what we pick up objectively by looking at an EKG strip.
Okay, that's very clear. So everyone, when you have palpitation, you may not have any objective findings. That's what Dr. Elkin said. But you may not feel anything, but you also have arrhythmia. Right. Dr. Elkin?
Absolutely.
Okay.
Especially if they're on a medication that slows their heart rate. I've had patients, I have a patient about a year or so ago. She calls me, she says, I think I'm in atrial fibrillation. I said, how do you feel? She said, I don't feel anything, but my iWatch told me. So now the updated iWatches can actually tell you if you're in atrial fibrillation. It happened to her twice.
Yes. iWatch, important. Yes. I spoke to some of my cardiologist friends. They said just have the Fitbit for exercise or iWatch, and it will tell you about if you have any arrhythmia. Now, I know it's 30 minutes, but I have a few questions here from the audience. Can you answer it, please?
Absolutely.
Yeah. Okay, let me read it for you. This one, okay, Dr. Cynthia has a good story here. She had a very, she has to perform. She is a performers. She is a comedian, and then she has a performance anxiety and a palpitation. As soon as she get on a stage, it goes away. Wow, that's good. And she does meditation. And then the question, she does meditation and deep breathing. The question is, are there any long-term problems associated with this type of palpitation?
I don't think so, because it seems to be emotionally based, anxiety prior to performing. And yet when she's up there on stage, she does fine. And she's doing what she should do, which is deep breathing and meditation, which again is Zen-like, and it helps to activate the vagus nerve. So when you're upset or when you're anticipating something, that's your sympathetic nervous system. That's fight or flight, so there's autonomic nervous system has two parts: sympathetic, which is fight or flight, excitement, heart rate goes fast, you're breathing fast. Then you have the parasympathetic, which helps with digestion and rest, and it's the calming part. So I think she's doing a great job. Would I do anything different? I think, if you're meditating and you feel okay on stage, I would not, there are some people, believe it or not, I'm not one of them, but there's some people that have performance anxiety and they take a beta blocker before they have to give a speech or give a toast. I mean, it seems to work for certain people because a beta blocker will actually cut down on the sympathetic drive. But again, I don't like to use drugs for things like that. I think you're doing
homeopathics.
Yes. Yes.
Homeopathics, right? Stress calm.
Exactly.
Iron. No, but she said palpitations, so probably she had done the Holters and found nothing. So I think your suggestion is pretty good, and hopefully so nothing will happen because she doesn't have any objective findings, right?
Okay.
Yeah. So another question from an audience here, Colin, how long do you meditate? Amount of the time, how long do you meditate?
Thank you. That really varies according to the individual as to how much time you have. I try to go at least 20 minutes a day in the morning, and I do it as soon as I wake up. I don't like shower and shave and do all that stuff first. I just sit myself up in bed because I don't want to go back to sleep, and I just work on my breath. And I do that for about 15, 20 minutes, after at least 18 minutes. Then the last couple of minutes, I start a little prayer thing. Now, I'm not necessarily talking about religion. I'm just talking about spirituality. So I pray for my patients. I pray for my family. I pray for people that are hurting. And that kind of helps to ground me for the day. Then I get up and jump into a cold shower. And I'm ready to start my day. And that works for me because I am basically an adrenaline junkie. Left to my own devices. So I have to work very hard to calm down and, so, and I've gotten good at it, but I had to work at it. It wasn't natural. I tend to be more of a hyper type.
Well, everyone should know Dr. Elkins is an exerciser. He does a heavy duty exercise, right, Dr. Elkins?
Yes, I do.
Yes, he has muscles everywhere. In fact, maybe his brain has muscle too. So now there's another one. Can the amount of magnesium needed by one body change throughout the year? I let you answer first.
Well, of course, you're the magnesium expert, but I say, of course, anything, because anything can change. Nothing is stagnant, especially when it comes to supplementation. Magnesium is a trace mineral. And like I said, it's so important. So I basically listen to the patient. I mean, I don't want them to have diarrhea, of course. And so that's important. But there's so many benefits to it. But it can change. Like I take for myself, and I don't need anything to sleep. I fall asleep within 2 minutes of hitting the pillow. But I generally take about 400 milligrams of magnesium every night before I go to bed because I know I need it.
Mm-hmm.
And I sleep very peacefully. Now, some people also have to take it throughout the day because of palpitations. Palpitations is a very common cause, a reason rather. So it really depends on the individual. And yes, things may change according to what's going on in your life. Are you under stress? And, I think the last 6 to 15, 16 months, we've seen a lot of stress, certainly in my practice, and I'm sure in Dr. Maria's as well. It's just been, it's very, very tough, and it's still tough.
Mm-hmm. Mm-hmm.
So things change.
But allow me to use a minute to mention a little bit about that questions. So especially in the cardiology department, this is what I learned from Dr. Abraham Gee, who had published 17 peer-reviewed journal about magnesium. Now, he had passed away and he owned the Optimax company before, where he actually, did several type of magnesium for cardiology, for pregnancy, and for people who has chronic fatigue. Now, the magnesium in cardiology system actually helps the transportation of the calcium to the bones. So then the vitamin K and the strontium will actually glue it to the bone. So the calcium does not travel in the cardiovascular system. If you do not have enough magnesium and you think that the calcium helps you to sleep or helps you to relax, but it's the other way around. Basically, calcium to magnesium ratio should be 1:2 ratio, or at least 1:1 ratio if you cannot tolerate magnesium. But if you cannot tolerate magnesium, you should review. You need the magnesium, the most absorbable one, which is bisglycinate, so that it doesn't irritate in the gastrointestinal and you would have less diarrhea or a soft stool. However, if you take calcium gluconate, calcium glycinate, calcium aspartate, all of those can actually irritate the gastrointestinal. However, you need to make sure, take the magnesium first, and then you see if you tolerate 600 milligram magnesium, let's say, of whatever magnesium you choose, you cannot take more than 600 milligram of calcium to reduce the chance of calcification or calcified plaques or whatever in the joints, in the
Well,
cardiovascular system. So you have to understand that.
I'm so glad you mentioned that, because years ago, like 15 years ago, we would give women that were menopausal like 1,500 milligrams of calcium. But we just gave calcium because we knew that was part of the bone. Now we knew that we did the wrong thing because it was going to the wrong place. It was going to the heart valves and the coronary arteries. So now I do use calcium, but I use much smaller amounts. And magnesium is a plus, vitamin D is a plus, vitamin K2, and boron and strontium. We didn't know that 15, 20 years ago.
Correct.
We were using calcium, and that could explain why so many people have calcified arteries. So a good point. Thank you for bringing it up. Well, may I ask you one question? What's your feeling about topical magnesiums? Some of my patients, they swear by it. They put it on their feet. They bathe in Epsom salts. What's your feeling?
Oh, good. It was not available, but now all kind of magnesium. You can dip yourself in the bath and you would just put magnesium there, and it does good. Everything does very good. And don't forget, when you check the magnesium, check it red blood cell magnesium, not plasma. And then you will know where you are. You have to be at least 5 and above. If you are 5 and below, or it's not good. You have to know where your magnesium level is, because magnesium, I call it the king of the mineral.
I agree.
Yeah. One more question here, and he's the registered nurse, so he knows what he would like to ask here. He said, when you turn your head on the pillow you sleep on, you can hear your heartbeats sometimes. It is steady and some bradycardia or sometimes tachycardia. Should have it checked it out?
I've been getting this common. It's a common complaint I've been hearing for the 35 years I've been in practice, and I've never been able to get an explanation for it. Again, I think it's because certain people just are more aware of it than other people. I mean, I've never heard it, but would I be worried about it? No. I mean, if it's only happening then, it just could be. A lot of people will feel these palpitations at night when they're resting, when they're watching TV. During the day they're so busy they don't recognize it, they don't experience it. So it's probably not much to be concerned with. I can't give you an explanation. I don't think anyone can, but if there's any question at all, and here's the point I want to leave you with. If you see a change, let's say you do have palpitations on occasion, if you see them being more frequent, more severe, any change in pattern, that's when you want to get checked out.
Oh yes, thank you so much. Any take home message before I close this conversation? Is very interesting, but it's already 40 minutes.
The important thing is just to know your body, and I know a lot of doctors are famous for it. One of the main complaints of doctors that I've always heard with surveys is that the patients don't feel heard. And this is a situation which you need to have a doctor that will hear you. because like I said, palpitations mean different things to different people. So I have to really sit down and listen to what the patient says. So make sure you see someone that will listen to you, because they have to know, is this something that we needs to be worked up, or does it not need to be worked up? And that's really the take home message. It's being your own medical advocate, which is my thing. Is I want patients to know, I want you people out there to feel empowered. You know, you want to go to good doctors, but at the same token, you need to take responsibility, and part of that is knowing your body. So that's a big thing.
Thank you. So everyone, some of you had asked me his information, where he practices. So Dr. Howard Elkin is a practicing integrative cardiologist in Whittier, California. It's not too far from where I practice. And the website is called HeartWise, WISE.com. And he actually has his own YouTube, and he called the medical advocate Howard Elkin, MD. And he also are on Instagram, and the address is DOCH Elkin. Okay, so now you can hear his other YouTube announcement or YouTube channel. So thank you so much, Dr. Elkin.
Thank
And
you.
thank you for
That's
coming to my YouTube several times. Yes, I'm Dr. Maria Sulindro, practicing integrative anti-aging in Pasadena, California. I'll see you next week. Bye.